Hi, everybody. I'm Ann Budzak. I know some of you, and I'm a pediatrician at Gunderson. I've been there for 26 years, which is going to be a really long time. My work surrounds child abuse pediatrics, and so I'm here to talk to you about, share with you about a new program that we started this past December called GunderKids. And it's very exciting to me. This is mainly going to surround our youngest members of our community. That is who the program is for. For those of you who are in education, of course, these little guys grow up to be bigger little people, and they become part of your classrooms. And the reason this came to be, this GunderKids program, was because day after day, week after week, I was seeing children from our region who had been traumatized in a number of ways. They were being hurt, they were being molested, they were being tortured, they were being beaten, and although I was happy to try to be part of their care and meet the needs that they had right then and there, the question in my mind was, how do we prevent this from happening? How do we stop this? How do we put me out of business as a child abuse pediatrician? What can we do so that this never happens to a child? And so GunderKids was born. When looking at high-risk populations, children born to drug-addicted parents are at extremely high risk for maltreatment and abuse and trauma on multiple levels. And so to begin a program for our socially complex families, this seemed like an obvious population and one we could identify and begin working with from literally the moment of birth. And so talking about substance abuse, I think, is a logical place to start because it's extremely prevalent in our community, as it is in every community in our country. There really isn't a place you can go where this isn't a huge issue. And it doesn't matter if you're in a rural area or if you're in a big city, because it's everywhere. And it is here and continuing to grow. So many of you have probably heard about opiate addiction. We'll review just a little bit about it and how it affects children, especially the unborn. This is often the starting place for the problem. People get a prescription for pain meds because of an injury, an illness, and they keep taking them, and they get more, and they get more. Eventually, they can't get more, and they switch to what they can get on the street. Now, you can still buy prescription pain meds, Oxycontin, oxycodone, Percocet. You can buy it illegally on the street, but it's cheaper to buy heroin, which does the same thing. And so those who are using will switch from the pills to heroin in its multiple forms, whether it's smoked, whether it's injected. There are several ways to use it, and they become addicted. If you stop using, you get very, very, very sick, and so that reinforces the need to keep using, along with the other addictive nature of the drug. So the challenge is that babies are being born addicted to opiates, as well as many other substances, but opiates are the one that have the highest numbers right now across the country and in our area. This is data from 2012. So if every 25 minutes in this country in 2012 a baby was born struggling with opioid withdrawal, I would say at this point it's probably more like every 15 minutes, because those numbers have continued to go up at an astronomical rate. And so the problem isn't going away, it's getting bigger. The last data we have is from 2014, so 2 years ago, there were nearly 2 million Americans addicted to prescription pain meds, and another 10 million that would admit that they're using prescription pain meds for a non-medical reason. And 500,000 back then were addicted to heroin. So you can increase those numbers quite a bit for 2016 because it keeps going up. And people die here in our community, as well as across the country, from overdoses of both the prescription pain meds and heroin. Doctors clearly have some responsibility in this problem because we've been writing prescriptions at a crazy rate over the last 15 years. We've written more and more and more prescriptions. Certainly doctors are not out to create addicts, but I think if we look at our society, we have people in pain for a number of reasons, and they turn to medical providers to end that pain. Chronic pain is something I don't think we heard a lot about 20 to 30 years ago, but now chronic pain syndromes are incredibly common. And it's not just older people. Everybody's body hurts more the older we get. I can attest to that. But it's young people too, okay? So there's clearly a problem with the number of prescriptions being written, and that problem is being addressed. Physicians are being provided more and more education about the risks of prescribing and how much to prescribe and to whom to prescribe, and being taught alternative approaches to pain for their patients that they can pass on. Doesn't mean the problem has gone away. We still have a problem there. So, as I said, the process of addiction often starts with the pills and then goes to heroin, and heroin is easier to get and less expensive than more prescription pain meds when you are buying street drugs. Some of you work with teenagers, and we have teenagers who are using prescription pain meds and heroin as well, right here in La Crosse as well as across the country. And they're big numbers. This isn't just one rare troubled teen. This is many, many, many teenagers. Women are extremely likely to be polysubstance abusers compared to men. Men will often stick to one drug of choice, whereas women will use many. But opioids, whether in prescription or heroin form, is a very popular drug of choice in our area. And women tend to seek prescription meds from their physicians more often than men. They tend to go to the doctor more often than men, so that only makes sense. So we get to the point of this whole discussion today. If moms are using, babies are using. Teenagers have babies, women have babies. We've got a whole population of babies being born to moms who are using, okay? And there are a lot of risks associated with using opioids in pregnancy. There are a lot of problems that babies have because of this. From prematurity, small for gestational age, preterm labor and abruptio placenta, which means that the placenta unattaches in utero, which obviously is a medical emergency and will lead to a dead baby if that baby isn't delivered immediately. A lot of fetal distress, that's meconium is the first bowel movement that babies have, and a sign of distress is that they're passing that before they're born. And birth defects, heart defects, hearing, learning, developmental delays. There's lots of different birth defects we see because of using these drugs. There's also a huge danger of abruptly stopping the drugs during pregnancy. The biggest danger is preterm labor, fetal distress, and fetal demise, or baby dying in utero, okay? So it's really a hard problem because we say, well, women who are pregnant shouldn't use, but what if you're already using and then you get pregnant? You can't just stop, okay, without a lot of risks. But you can't continue without a lot of risks. So we're stuck, right? Methadone and Suboxone are two medications which are used in opioid-assisted therapy. So they are opioids. They have some qualities to them that make them less likely to be abused, but you can abuse them, okay? They are given normally by prescription through a drug program. We have programs at both medical centers here in La Crosse for substance abuse. We also have an independent program called AMS out by Woodman's, and that's purely methadone. Methadone and Suboxone are prescribed at the two different medical facilities through their addiction medicine departments. There's lots of regulations that go with that. In the medical centers, there is therapy that's required to go with that. The idea behind it is a controlled dose of opioid, and the benefits to the unborn baby are that the dose is not going to dramatically waver from day to day, week to week. It is not, the baby will not be subjected to withdrawal use, and there are a lot of incentives for that woman to receive prenatal care if she's in this program. It is likely to help her leave the drug life and the risks of that. It also decreases the cravings for using heroin or the other opioids, so it helps in that way. The tough thing is that it still affects babies, okay? So it's better than the street drugs. It's controlled, there are lots of benefits, but it doesn't prevent problems for babies because it's still opioids. They're still having that in their developing bodies and brains. And when they are born, the medicine is no longer in their system, right? Because they're not attached to mom anymore. And so the majority of these babies will go through withdrawal when they're born. And withdrawal is called Neonatal Abstinence Syndrome, or NAS, okay? If anybody has questions as I go on, feel free to stop me, okay? I'm happy to answer them. Yeah.
For the programs, does the pregnant mom need a referral from a pediatrician, from a midwife, or how does she get that referral, or can she just show up?
The pregnant mom?
Yep.
Wanting a referral to the addiction medicine program?
Yep.
I don't think she needs a referral. I think she can call and say that she would like to be seen. Now, there are limits on the number of patients each provider can manage when dispensing methadone or Suboxone. That's government imposed. So trying to get treatment doesn't always mean you will. However, if you're pregnant, the priority goes way up. You jump the line, so to speak. At Gunderson, one of our obstetricians, Dr. Schauberger, manages the majority of moms who have substance abuse issues, and he too will prescribe methadone and Suboxone.
And one more question with that. I work
Yeah.
with school-age parents.
Uh-huh.
So some of the questions are, will CPS get involved? And how do I answer that? How would you suggest answering that?
CPS gets involved if there are drugs of abuse in the baby system at birth.
Okay.
It is mandated by law that they are informed. The goal of CPS is to provide support to these parents, not to take the baby away.
Okay.
And if the parents are doing what they need to do during pregnancy, if they are getting treatment, if they're going to appointments, if they're getting prenatal care, if they're not landing in jail, if they're not, breaking into people's homes to steal whatever to get drugs, there's no reason CPS would want to remove that baby. So, yes, but is the...
Okay.
And if they think that by not seeking treatment, they'll avoid CPS, it's going to happen no matter what.
Okay.
It's just what choices they make leading up to it as to how much involvement.
Okay.
So this is just another graphic showing you the dramatic increase in the last several years of number of babies who have neonatal abstinence syndrome. And that's who's recognized. Now remember, there are people who will go through a pregnancy and seek very little prenatal care or not disclose that they're using. And if they are if they're trying to beat the system and their babies are not showing dramatic withdrawal symptoms in the first 48 hours after delivery, they might be able to skip the hospital and no one ever know. But then they go home with a baby that does withdraw. Does the pediatrician recognize that's what's going on when they come in because the baby is having lots of issues? So what I'm saying is the numbers aren't perfect by any means, and what I'm learning is a lot of physicians don't recognize NAS. Or what they know about it is very limited, and they think that if the baby doesn't have dramatic symptoms in the hospital in the first 3 days, they must not have NAS, which is very untrue. So, what is NAS? What does it look like in a newborn? These babies are probably the hardest babies on the planet to take care of. They are irritable, they are crying in a way that's very hard to listen to, and they do it all the time. They are hard to soothe, they shake, they're very jittery, they throw up, they're hard to feed, they have trouble gaining weight even when they're eating adequately. They have diarrhea, they sneeze constantly, they hiccup constantly. All babies do some of that, but these babies do it a lot. And they can have seizures. They don't respond to the typical soothing things that we would all possibly instinctually try. Now remember, in this population, many of these moms have not had the parenting that leads to some intuitive parenting themselves, okay? So we're handing horribly challenging babies to moms with very little inherent resources and resilience to parent these babies, okay? In the hospital, when we know a baby is at risk for withdrawal, we routinely at Gunderson monitor them for 72 hours, 3 days, okay? During that time, we will often see the symptoms if they're going to be there, but not always, okay? It's thought that most babies will start to show withdrawal in 72 hours, but I can tell you that it can take a week, it can take 2 weeks. The literature says up to 4 weeks. I can't say that I've personally seen it take that long, but I've seen it take a couple weeks, okay? Yeah.
What are tests for the difference?
Some of it is the amount of medicine mom's on. Some of it is what other medicines she's on, whether she smokes, whether She did other drugs that she didn't disclose during pregnancy. Lots of different variables. And individual variables within baby to baby as well, even if we kept all of those things the same. So NAS symptoms can last for months. And imagine having a baby like that for months. That's why this is such a high-risk population, or one of the reasons. And the tough thing is the symptoms of NAS can change over time. This is the scoring system, Finnegan scoring, that we use in the hospital for those first 72 hours. Every 3 to 4 hours, trained nurses on our postpartum unit are assessing babies and scoring them. They also are teaching the parents how to assess them, and they participate in this. If they have an elevated score, then a second nurse is asked to come in and also score to make sure that we're being objective and that we're getting good information. There's 31 different items, and the score for each item is anywhere from a 1 to a 5, and then you add them. Any score, if they get 3 scores of 8 or higher consecutively, then they are felt to be a candidate for medication treatment for their withdrawal. And the most common medication used is morphine. So these babies are started on morphine to help them with their withdrawal. Okay?
How long do they stay on that kind of medication?
So they are given the medication at incremental doses till the symptoms are managed, and then they are very slowly weaned off. The average stay for babies on morphine is 3 to 4 weeks. So it's a very slow process. There are lots of other things we try for withdrawal besides morphine, and these are all taught to parents. These babies need a quiet environment with low stimulus. They do better if the lights are low and it's quiet and calm as much of the time as possible. They do better if we're not moving them around constantly, and when we do have to transition them for diaper changes or putting clean clothes on or bathing, we're doing it slowly, patiently, and working up to each move rather than just going for it. Okay, and these things are taught to parents. We have an occupational therapist that comes in and teaches this, as well as our nursing staff. These babies need higher calorie formula usually in order to gain weight than babies without NAS. We teach parents how to position them. They do better with a vertical rocking if they need soothing than the horizontal rocking that most of us would instinctually do. They don't handle this very well, but they handle this and respond to this. We try to teach moms how to manage stress because this is a stressful experience. And we encourage them to breastfeed because they get a little bit of the Suboxone or methadone that mom's still on through the breast milk, and that will ease the symptoms and we can more slowly withdraw it than if they are abruptly cut off from what they had been getting through the placenta before birth. So we talked about this. It's not unusual for them to be in the hospital for 4 weeks if they need morphine. And when they do go home, then we give them a list of things to watch for that they need to let us know about. Now we've centered on opioids, but there are lots of other drugs that will also cause withdrawal. It's not just heroin and oxy that do it, but amphetamines, meth is again still a huge issue in our community. Lots of people abuse methamphetamine. Antidepressants can cause some withdrawal. Barbiturates, benzos, a lot of people that use Xanax and medications in that family of drugs. Even caffeine and nicotine cause withdrawal, and some nicotine especially causes some long-term problems, and marijuana. We have a lot of folks who see marijuana as a non-issue or not a drug to get excited about, and that's not true. It can cause long-term problems developmentally for babies that are exposed to it on a significant level during pregnancy. So I have a list of the different drugs and what they do. The withdrawal often looks very similar as far as the baby is concerned, no matter which of these we're talking about. Babies have, as newborns, kind of a limited repertoire of things they can do, as you guys know, and ways they can express how they feel. And so, although I've listed for you the specifics for each drug, quite honestly, when you step back and look, they all look pretty similar. It's just how long will it last, and is there anything we can do other than the comfort and soothing techniques that we've talked about. Most don't have a medication that we could give for extreme cases, but it doesn't mean it isn't hard. It doesn't mean it isn't challenging for the parent. I think for parents who use marijuana daily, this is a big eye-opener because they truly believe they've done nothing harmful during pregnancy to their babies, despite people trying to educate them otherwise. So up to a month after birth for babies who have had significant marijuana exposure over time. And for you all, probably the long-term effects are what you're most interested in. So children who are exposed prenatally to a lot of marijuana have, as far as research goes, attention issues. They have slower acquisition of visual perceptual tasks and language skills, and they can have increased levels of aggression, which is interesting because a lot of people believe that THC mellows you out, but not if you're a developing baby in utero. Meth, along with ecstasy and stimulants, can lead to withdrawal for the first couple of weeks, and these babies look just like opioid withdrawal babies. And at the end, I've got a list of what that does. The long-term exposure causes developmental delays, cognitive impairment, learning disabilities. They have trouble with emotional regulation and executive functioning. They tend to be little, they grow slower, and they can have attention challenges. Now, some of this is also very true of kids when exposed to meth ongoing as young children. So let's say your second grader wasn't prenatally exposed, but parents started using when they were 3 or 4. People have some misconceptions about what that does to kids. And I'll take a moment to say, we got very excited about meth manufacture about 10 years ago and meth labs and how dangerous that was to kids, and it is very dangerous. There's a lot of toxic chemicals involved in a cook. But it is extremely harmful to live in a home where people are smoking meth on a regular basis, because meth hangs around in surfaces. It hangs around in the paint. It hangs around in the carpet fibers. It hangs around on cloth toys. It hangs around on the couch fibers. It's everywhere on every surface. And if you're a little person, if you're a toddler, what do? You put everything in your mouth. So you're literally ingesting meth residue. It also comes out in the skin. So skin oils, if you are a user, you have meth on your skin after you've used. And it keeps coming out because it stays in your body for several hours. So when we see kids who are living in a meth-using home, guess what? You'll see this. You will see kids who have trouble focusing. You will see kids who have difficulty with emotional regulation. You will see kids who have trouble with executive functioning and cognitive challenges. Now, here's the tough part. If they're living in a home where people are using meth on a regular basis, they're also living in a home where there is a lot of toxic stress. They're living in a home where there is very little organization, very little schedule, very little predictability. They don't know when mom's gonna remember that they need to eat, or that they need to eat, or that they need to go to school, or that they have a backpack with homework, or a take-home folder to check, and you guys have seen this. You've seen this. So how do we separate the meth part from that environment? And I can't tell you that there is a good way. There's one research article in the literature where parents, moms who are breastfeeding, agreed to take a certain amount of meth, ingest it, and then pump so we could see how much came out in breast milk. That's as close as we can get to measuring, one little piece of this, but there's obviously no research that can separate kids who are being exposed to meth from kids that are living in a meth environment and the chaos that is part of that. Sorry to go on a little tangent, but
On the previous slide, you had, one of the drugs of choice was Adderall or antidepressants and stuff. If the mom is taking that for her own health and not abusing it in any way, is it still going to adversely affect the child?
it can.
It can?
It can.
Okay.
Now, there's lots of active research right now on antidepressants specifically, and so I caution you that although there is a possibility of causing problems, it's extremely important to not walk out of here and say nobody should be on antidepressants when they're pregnant, okay? Because it depends on the drug, it depends on the dose, and it depends on what the risks would be if that mom is not taking an antidepressant while pregnant. So, yes, there's risks, but in medicine we're often constantly weighing the risk versus the benefit, and the jury is not out yet on what exactly each different antidepressant might do to the baby, and what the long-term implications are. But good pickup and good question. Benzos, again, the withdrawal is very similar to opioids, and there is a treatment, phenobarbital, for those that are really having a hard time. Cocaine is still very popular in our area. There are lots of people who abuse cocaine, and they're saying it isn't really withdrawal, it's neurotoxicity, but quite honestly, that's about the same thing in my book, and it looks the same as all of these others. The interesting thing is these babies, after initially being really irritable and jittery like all of the others, they can then get kind of pokey and lethargic and non-responsive for quite a long time. And that's a little bit different than the other withdrawal symptoms. As far as what happens long-term, again, cognitive challenges, behavioral difficulties, and a little bit of hypertonia that can last for many years in these kids. Antidepressants. Again, this is probably one of the shorter withdrawals that we see, and it can be up to 2 weeks. It's often just a matter of a couple of days. Now, this is one of the drugs, though, that impacts if you're also on Suboxone or methadone and you're on an antidepressant, which is not uncommon. The two can work together to make the withdrawal symptoms more impressive or more intense. Caffeine makes jittery babies. The withdrawal lasts usually just a couple of days, and generally this is people who are doing a lot of caffeine every day. So if you are somebody that has one Diet Coke or 1 cup of coffee during pregnancy, it is unlikely to end up causing these problems. But if you are chugging energy drinks 5 to 8 times a day, and that's a whole different story. Or you're drinking 2 pots of coffee a day, or, so. Nicotine is almost universally part of our substance abusing mom's life. And so this, again, it's additive to the other withdrawal and can make it more dramatic. This is something that I don't think we do a good job of publicizing to pregnant moms everywhere, because obviously many people still smoke. less than 20 or 30 or 50 years ago, but there's still lots of smokers. And it has long-term effects. We have littler babies. They have littler heads. And there's an increased risk of being born prematurely if you are a smoker who is pregnant. You have an increased risk of SIDS once that baby is born and home. And there are associated attention issues, IQ, cognitive issues, behavior issues that go with being prenatally exposed to nicotine. And then alcohol has been known for a long time.
On the previous slide, the altered tone, did you mean by their cry, you can generally tell, or this under the symptoms?
Nope, altered tone is how limp or how tight their muscles are.
Okay.
And they tend to be more tight. And then fetal alcohol syndrome, I'm guessing if I had to pick one drug of abuse, this might be the one you guys are most familiar with because the information's been out for a long time about the devastating long-term effects of excess alcohol exposure in utero. Again, these are little kids with smaller heads, cognitive impairment, learning disabilities, behavioral challenges. All of this is kind of starting to sound the same, isn't it? So, back to heroin or methadone or Suboxone. We have learning challenges, developmental delays, behavioral regulation challenges. They have some delay in their acquiring motor milestones and small heads. We're finally going to talk about GunderKids. So what is the program and why? So postpartum is a really high-risk time for these moms to relapse and begin using again. And there's lots of different reasons. Any of you who have had a small baby in your home might remember the sleepless nights, the stress, if it's a first baby, having no clue what you're doing, even though you read every book known to man, and not as much help as you expected to get from someone else in the home, if there was somebody else in the home. And that never changed. No. And then all of a sudden, this baby that you worked really hard during pregnancy to try to be as healthy a person as you could be, well, that baby's not here anymore, it's here, so wouldn't taking the edge off by, a little hit of this or that make this easier when it's really, really stressful? That's very tempting. The moms who go to Gunderson for their prenatal care, by and large, see Dr. Schauberger, and he has a team of nurse managers, a social worker, a therapist, and moms who did receive their prenatal care regularly would say over and over that they felt really supported during their pregnancy. They really liked the care they got. But then this baby would be born and everybody went away. They aren't pregnant anymore. Now they're just kind of thrown into the world, and you go see your baby doctor a couple days after you go home, then at 2 weeks, then at 2 months, and it's just, there's nobody there checking on you. And they said they felt really abandoned. The other challenge is we have lots of awesome in-home services for people with new babies that want help with parenting, want help with learning what to do, and support with the other challenges they have, such as housing and food insecurity and transportation. But guess what? Most of these families or moms didn't take advantage of those services because it meant somebody would come into their home and be in their business. And so they would universally say no, which is unfortunate because we have awesome, awesome programming. Healthy Families, Parenting Place, lots of services, but it would be a flat out, I don't want that. So what could we do to help these folks? GunderKids was born. So we patterned this after Dr. Schauberger's model, and we have currently one pediatrician, I have 2 full-time pediatric nurses dedicated to the program. I have a pediatric social worker that's part of the program, and I have a child psychologist who is within the Department of Pediatrics who is part of the program. We have an extensive curriculum. We have hour-long visits, and we see these folks 17 times in the first year of life. We see them within 1 to 2 days going home from the hospital, then we see them weekly until the baby is a month old, and every other week till the baby's 4 months old, and then once a month till the baby is 9 months old, and then every 6 weeks till they're a year. Every visit, we check in on all of those challenges. Who's living in the home now? Are you getting help? Are you getting sleep? Do you have enough to eat? Could you pay your electric bill or your heating bill? Did you have trouble getting here? Are you having trouble getting other places? How are you doing with your sobriety? Are you going to therapy? All of that is asked every single visit. Can we help you with any of that? We also have a curriculum of teaching about parenting, about normal child development, about the NAS soothing, and we review those techniques and tailor them to what they're experiencing and how to help. We talk about safe sleep, we talk about car seats and all of those traditional things as well, but we are definitely focused on the challenges that are unique to each family. We welcome dads, and we actually have a number of dads who come. Or we welcome whoever that support person is that mom may see as her support. Now, some babies don't go home with moms, they go directly to foster care from the hospital, but if mom is going to be involved and working towards regaining custody, then we still take them into the program, and as long as mom comes to every visit along with foster mom and baby, it's no different. And we've actually had 2 babies since December start that way and be returned to mom's care full time, and she's gotten custody back. So it works. Yeah.
Maybe you're going to get to this, but is it funded through insurance? Can anyone come, even if there's
Anyone can come. No. So if you have Mayo insurance, Mayo won't pay for you to come to Gunderson for
Do
this.
you know if Mayo has something?
They don't. No. Quite honestly, all of our moms so far have had Badger Care medical assistance. And they can switch, if they have traditionally been a Mayo choice of the 2, why am I blanking? Thank you. They can request a switch, but by and large, they're gonna have delivered at Mayo, and they're not gonna know about this program. We, and I'll get to this, we go and meet with moms during pregnancy actually, and try to introduce the program and recruit them when they are about a little over halfway through their pregnancy. So they know about this ahead of time. And then if they agree, we give them some information at the time. And then my nurses and I meet them in the hospital once the baby's born. We get notified that the baby is here, and we'll go up and talk with them. Now, if they say no when we meet in pregnancy, we'll go up and talk with them one more time when the baby's born. Sometimes just the baby being there changes people's minds, and so we'll offer one more time. If they still say no, that's fine, it's voluntary. Yeah.
Are these women who've been referred by their doctor, or they've expressed interest, or how do you?
They're all Dr. Schauberger's patients,
Okay.
because that's who cares for them at Gunderson.
Okay.
Dr. Merkich has a few, and he too will let us, because it's the same care coordinator nurses, so they give us a heads up when they have a patient who they think would be appropriate for the program.
So has this become full-time now for you, as opposed to, I know you were doing a lot in urgent care when my kids were little.
I don't do urgent care at
You're
all
not doing
anymore. I
that.
don't have a
This
general
is-
practice anymore.
Okay.
I do child abuse pediatrics in this full-time.
Okay.
I have a foster care assessment clinic that I created for foster kids. And so I still do abuse,
Mhm.
and I do this, and that's pretty much all I do.
I can imagine.
Who helps then coordinate if they are a family that needs food, or they do need?
Our social worker.
Okay.
So she
that's,
does community
yep,
resources.
yep, she has a volume of community resources, contacts, and she meets with the families each visit, and then will give them resources and do contacts on her own to try to create resources. So we then see them, and as I said, we see them very, very frequently. My nurses have their own direct phone line. They carry it like a cell phone. It's a Gunderson phone, but it's so that these moms don't have to go through our whole phone system to get a hold of one of the two nurses, and can call with any questions that they have. And we try really hard to encourage them to call us if they have worries, not show up at the ER or the urgent care, which is traditionally where this population tends to get all of their medical care episodically. And we're following that to see if that's successful, and so far it looks like it has been. Now this is a population where you can't always count on seeing the people on your schedule that are on your schedule at the start of the day. We've learned that it is, it's variable. And so if you change your expectations, you aren't frustrated or disappointed. And we track them. So if they don't show up, we're calling them. And some of them say, I really want you to remind me that day and the day before. And so we do that. And if they don't show, then we call them and we get them in the next day or the day after. I know that if they're supposed to see me at 9 o'clock, it might be 10:30, and that's okay. As long as they're there, that's the important thing. And we are going to welcome them regardless. If we're starting to lose somebody and we see that they are in some other area of the clinic, through their chart, we can see what their other appointments are. My nurses will go over to that appointment and say, hi, how you doing? And guess what, it works. And it's not, you might say, well, they feel like they're being stalked. No, they aren't. They are like, oh, I know you, wow, you came here, because you wanted to see me. And it's very well received, and we've gotten people back on track that way. So it's, it's a different way of practicing medicine, but the idea is to meet the needs of the patient. So we currently have 36 babies, and we started December 1st. So we are completing our 9th month. Dr. Schauberger estimates that he has 30 pregnant women who have substance abuse problems at any given time in his practice in pregnancy. And so this is a population that is growing, and we are making plans for how we'll continue to accommodate, because unlike Dr. Schauberger, our patients stay with us not 9 months, but 18 years. So it's rapidly growing, and we've learned so much. So why do we do this? Number one goal, obviously, is that we want to grow healthy babies. We also want to help these moms and dads be the most successful parents they can be. And you know what? They want to be good parents just like all of us. There is no difference there. They want their babies to be healthy. They want their babies to have a wonderful life. They want their babies to have a life different from the life they've known. And they want to be good parents. They want to stay sober, but they can't always stay sober, because addiction is a disease. We want to try to keep moms and babies together. That's a huge goal. But obviously, if a baby is suffering because of the environment they're in, we are not going to turn a blind eye to that. We're going to get resources, and we're also going to get CPS involved if we have to. Okay? Huge goal is to prevent child abuse. We're measuring, we have active research going for this program to try to develop some evidence-based practice. So there's lots of metrics that we are following that we will hopefully be able to collect, we are collecting, analyze, and eventually publish. So we want to see if these babies grow appropriately compared to babies that declined the program. We want to see if they're getting their immunizations as they should, if they're keeping their appointments with us, how often they're going to the ER or urgent care versus coming to see us, if they're getting readmitted to the hospital. We have a number of, if they're seeing our behavioral health specialist at the appointed stage of the program, we have a number of different analyses that we do. PSI is Parent Stress Index. I don't know if any of you are familiar with that. CAPI is Child Abuse Potential Inventory. So we have them take that in the first 2 months of the program, and then again towards the end of the first year of life. We're going to compare scores and also get some knowledge of just what does our population look like from these perspectives. We have a caregiver satisfaction survey and a caregiver well-being survey. We do those twice in the beginning and towards the end of the first year. We will follow how many parents lose or maintain custody of their children in the first year, and how many patients have a diagnosis of maltreatment at the end of the first year. So, we've learned a lot in 9 months. I've learned a ton in 9 months. I will tell you, this is the most inspiring work I've ever done in my career. And it makes me want to go to work every single day. The number one reason that this is working, these folks are by and large coming to their appointments, they are participating, they are succeeding, they are parenting well, and they have healthy, thriving babies. It's not anything magic that I'm personally doing. It's the relationship that we have built with these moms, especially my nurses. My 2 nurses become a very important part of these families' lives. And it's that relationship that makes it work. It's incredibly important when working with this population that you approach them with respect and you leave your judgment at the door. What I know is that all of the parents I have worked with so far have trauma histories. Now, they're not going to tell you that the first, second, or third time you see them, but eventually you learn about the lives they have led that led to their substance abuse. And if I had led the lives they have led, I would be using also. I would have looked for some way to cope and survive. And so we can look at people who have addiction and say, well, if you just didn't do that, you wouldn't screw up your kids and da 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 da, right? Wrong. Often, these are families who have multiple generations of abuse history. These moms and dads learn to cope using substances because their moms and dads, their grandparents, their aunt and uncles, that was how the family functioned, okay? And they want desperately to not continue that story for their own children. They want very much to be successful, and they want very much to keep their children. And it is well worth the time and energy, but it takes a lot of work to build trust and convince them that our goal is not to take their babies away. Their walls are this high when they come to us for the first visit and the second visit. My nurses say it takes 3 visits. They know better than I do. Remember, as you work with these families in your own work environment, classroom or office, addiction's a chronic disease. It has its ups, it has its downs. It is something that no one with addiction wants to have, any more than someone with diabetes wants to be diabetic. They would love to not have this problem, and there's so much stigma attached to it that it is a very hard problem to be open and upfront about. And there are years of learned behaviors that go with it that sometimes make it more challenging to be helpful to this population and work with them, but it's well worth the effort. So, what questions can I answer?
How long do you stay with the families?
Till I retire. We intend to stay with them until their child graduates pediatrics.
Oh, okay.
So we're doing research on the first year of life.
Yeah.
But the program will continue. Our hope is, we have one baby that will turn a year old in September because he was an extreme preemie who left the NICU at the start of our program in December. Our hope is that once they've completed their first year, that we can possibly have them go to more of the traditional pediatric well visits with additional education still at those visits, but that they won't continue to see us as often. We've been gradually kind of weaning them down on how often they come as they approach the first birthday. Now, if we find that they really need to be in more often, we'll do that. We have a handful that when we start weaning down, they don't want to go that long. So we say, okay, well then, when would you like to come back next? Flexibility is huge, and so we try to meet each individual family's needs, and we're not going to, rigidly stick to any schedule.
I'm not sure if this has occurred, but if the parent is continually having issues with the substance abuse, is there a way to get them some sort of rehabilitation or put them in a program that would gear them towards possible recovery? There are ways. There are inpatient, there are, residential treatment. Now, having said that, there's not enough beds.
There's not enough money.
There's not enough money too. But the resources are very, very limited, and so that's a challenge.
Yeah.
But yes.
Are there parent infant rehab programs?
In Madison there is. That is the closest one that I'm aware of. I wish we had one. I would love to have one. Housing is one of the biggest challenges for these families, and if we could have an inpatient or residential treatment, mom and baby, it would be phenomenal. It would be well worth the investment in our community because there would be so much more we could do.
Will you continue to follow the families or when they?
Yes.
You will, till the
Yeah.
child's older, so you'll be a
Yep.
pediatrician for
Yep, although I'm old, so I do intend to retire at some point. It'll be at least 10 years from now. We've already begun planning for how do we accommodate the ongoing addition of new babies. Because obviously I'm going to max out and I still need to be doing the child abuse work that I do. So what are we going to do, because the numbers will continue until something else changes. So we are looking at adding more pediatricians that are interested in participating in the program. The consistency will be the nurses. We'll still have a team. The same nurses will work with the same families, but that family might see Dr. Randall or Dr. Manson or Dr. Gerhardt as far as the pediatrician part, so that we can accommodate more numbers. We hope to be able to spread this program to family practice, to Onalaska Pediatrics, to our regional. I mean, there's plenty of families. Right now, I have families driving from Black River Falls to see me every week. And they don't have resources, so that's a big ask. And yet they do it because that's how much they want to be successful.
One more question. Is there any coordination with birth to 3?
Yes, we refer many of our babies to birth to 3. Now again, the 3 comes to the home. So we have to do, it's a wonderful program, but we have to do a lot of song and dance to convince the families to let them in. And I would have to say that we are not always successful with that yet. But we try.
Please join me in thanking Dr. Hudson.